Good afternoon, ladies and gentlemen. It's my great pleasure and honor to host this section. And we are going to have the theme 2 of this afternoon section. That's multidimensional approach to autonomic disorder. What we have and what we have advanced. And I have the honor to introduce our next speaker, Peter Novak. Currently, he is the director of Autonomic Laboratory at Brigham Women's Hospital, Harvard Medical School. He is a board-certified neurologist and autonomy specialist. He graduated from Slovakia and completed his resident training in Ohio State University. He also had postdoctoral training in several distinct universities, including Charles University of Prague, University Montreal, McGill University of Canada, and at Mayo Clinic. So as you can see from his CV, actually he's an expert in this field, particularly in the autoimmune, small fiber, and the autonomic neuropathy. He has written over 70 papers and presented excellent studies in numerous conferences. Today, he will talk about the Sudoscan Clinical Utility in assessing autonomic system. This is a non-invasive system different from the so-called QRSART I have mentioned to you. So let's welcome Professor Peter Novak.
My name is Peter Novak. I am Associate Professor of Neurology at Brigham and Women's Hospital, and I'm Director of Autonomic Laboratory. And in next minutes, I will talk about Sudoscan and clinical utility in assessing autonomic system. Here are my disclosures. And I have to tell that we obtained a unit from Inveto Medical as a machine for checking, but otherwise, Inveto Medical was not involved in design or conductance of our clinical trials. At the beginning, few words about small fibers and related dysautonomia. So small fiber neuropathy is common, affecting millions of people worldwide, associated with considerable disability and sometimes even mortality or morbidity. Small fibers are thinly myelinated alpha A delta fibers and unmyelinated C fibers, and they can be classified into autonomic fibers or efferent, so they will send the impulse from the brain, and sensory or afferent. And small fiber neuropathy is due to dysfunction of the small fibers. And depending which side dominates, we call it autonomic small fiber neuropathy with predominant dysautonomia, or sensory small fiber neuropathy with prominent sensory symptoms, or mixed small fiber neuropathy, which is most common. And in this situation, dysautonomia is also present together with sensory disturbances. Typical sensory disturbances are distal burning sensation, numbness, and several pain syndromes. Cardiovascular autonomic neuropathy caused by diabetes is the most common cause of small fiber neuropathy. This diabetic neuropathy affecting their autonomic system is present up to 90% of patients with type 1 diabetes and up to 73% of patients with type 2 diabetes. So you can see it's very common. Few words about autonomic nervous system. Small fibers, they mediate autonomic functions, so they innervate all organs. And autonomic, small fibers are proper or efferent or motor or sensory or afferent. Regarding the function, sympathetic nerves, they mediate a fight or flight response, so they're more kind of activating. But our sympathetic system mainly mediate rest or digest, so it is more like a passive system. And autonomic fibers, because they are motor, we cannot feel them. So any damage of these fibers or dysfunction is causing dysautonomia, which manifests as end organ dysfunction. And depends which organ is affected, then corresponding problems. For example, if there is problems with the cardiovascular system, people have orthostatic intolerance. If fibers going to sweat glands are affected, people have troubles with control of the temperature. They have hyper or hyperhidrosis. They might have significant cold or hot intolerance. And this is an example how the small fibers look on the skin if we will do these tangential sections. Autonomic symptoms are very, the variety of them are known, and typical are orthostatic because autonomic nervous system helps to fight gravity. So typical orthostatic syndrome symptoms are lightheadedness or dizziness, palpitations, sense of weakness, tremulousness, shortness of breath. Shortness of breath is very characteristic for dysautonomia. Chest pain also is part of the small fiber neuropathy. And this exacerbation by heat, exercise, meals, and menses, all the symptoms. And also very common is hyper or hypohidrosis associated with cold and hot intolerance. There are several non-orthostatic symptoms, such as nausea, vomiting, bloating, diarrhea, constipation, abdominal pain, bladder symptoms, and pupillary symptoms. And there are symptoms we don't understand quite, but they are very common in patients with dysautonomia. Those are fatigue, brain fog, sleep disturbances, exacerbation of migraine. Almost everybody with dysautonomia had migraine. Myofascial pain and neuropathic pain or several other pain syndromes. So question is why to test or why we do autonomic testing? And the reason is simple because it is very difficult to assess small fibers or dysautonomia clinically at the office. We do routinely neurological examination, but to distinguish dysfunction of small or large fibers is very difficult because overlap of the function. So the testing has also other questions to be answered. Is the problem autonomic or due to small fiber dysfunction? For example, patient with orthostatic dizziness or numbness. And how bad it is. So for example, mild autonomic dysfunction failure can only minimally affect quality of life, but severe autonomic failure with orthostatic hypotension might have profound impact on the life. And also the question is, what can be done? Is necessary only do like diet, lifestyle modifications, or even medical therapy? So those questions are usually answered by autonomic testing. And we do fully quantitative autonomic testing, and this is our, we call it Brigham protocol, which is combination of autonomic functional testing with pseudomotor testing and with skin biopsy. So we are combining functional tests with morphological. And standard autonomic functional tests includes a deep breathing, Valsalva maneuver, tilt test, and we monitor heart rate, blood pressure, both continuous from finger and intermittent from the arm, and tidal CO2, respiratory frequency, and cerebral blood flow velocity from middle cerebral artery using transcranial Doppler. For pseudomotor functions, we use either QRSART, quantitative pseudomotor axon reflex test, or ESC, or Sudoscan. I will talk about this later. Those tests are very important, and they are complementing other tests because they are checking postganglionic functions, so they help in localizations. For example, abnormality in deep breathing or the tilt test will not tell you exactly where the lesion is, which helps pseudomotor abnormality will tell you that the lesion is postganglionic. And also we do skin biopsies for evaluation of epidermal and sweat gland nerve fiber density. which directly assess the morphology of the small fibers. So this is a description of quantitative autonomic testing. Again, we do parasympathetic evaluation using deep breathing. Sympathetic and parasympathetic functions are evaluated by Valsalva maneuver and the tilt test. And the sympathetic cholinergic function by pseudomotor testing, small fibers by skin biopsies. And we also measure or assess supine and standing catecholamines and some other markers of the autonomic functions if it depends on the protocol. And if we suspect autoimmune process, we evaluate several antibodies. And this is the article which describes the conductance of the autonomic testing in details. Before going to Sudoscan, a few words of, regarding QSART. This is standard test for evaluation of the pseudomotor functions in the United States. So I will use it as a reference. And how it works is it measures postganglionic sympathetic cholinergic functions. And this is how it works. So using iontophoresis, we are delivering acetylcholine inside the skin. Acetylcholine will stimulate the sweat glands, and via axonal reflex will spread this stimulation to the sweat glands around, and they will stimulate. They will be stimulated, and they will produce the sweat after some latency. So we measure the sweat output, which is proportional to the activity of the small fibers. This test is very specific for cholinergic dysfunction because it uses acetylcholine as a trigger, as a stimulus, but it is kind of complicated and it is not widely available. And a few words about the skin biopsy, because it directly assesses small fiber damage. It is minimal invasive procedure using punch 3 mm biopsy. It can be done repeatedly. No sutures are needed usually. And we have two types of the biopsy we use routinely. It is epidermal nerve fiber density, which evaluates epidermal or sensory fibers, and pseudomotor sweat gland nerve fiber density, which evaluates pseudomotor fibers. In the United States, commercial labs are available, so it is very easy to set up the process. So we essentially look on these epidermal fibers crossing the epidermis, and also the fibers innervating the sweat gland. Those are those linear areas. Now, electrochemical skin conductance. This test was developed to bypass problems with assessment of the small fibers, particularly the pseudomotor fibers. And how it works is it measures the flow of chloride ion induced by electric current. The activated sweat glands produce sweat with chloride ions. And the ion flow produced by sweat glands is then proportional to the level of stimulus and sweat gland function. So this is a schematic how it works by low grade of electric current. And this is very important to use a very low grade stimulation. Typically, the current is needed only less than 4 volts. It is such a low stimulation that most people even don't feel it. So this low level of stimulation but it has to have particular shape of stimulus. This stimulates the sweat glands, which they produce the chloride ion, which is being measured in this circuit. What is particular property of this method is it stimulates both cholinergic and adrenergic fibers. Most of the innervation of the sweat glands are via cholinergic fibers, about 80%, but still 20% of fibers are adrenergic. So this is potential advantage of the Sudoscan compared to QSART. And for a reason I will show you later on, we are using normative data divided by the kilogram by the weight adjustment, which increase sensitivity and specificity of the method. It is very simple to do. No patients stands and touch these electrodes, hands and feet, and it takes about 3 minutes to get all evaluation. And usually patients, they don't feel any current at all. And this machine is used more and more for the last few years. It was peak in 2019, 26 studies used it. There was some little delay, decreased last year. But in general, the use of Sudoscan is increasing. In our study, we have been interested to find out how Sudoscan or electrochemical skin conductance, how it correlates with direct measure of the sweat glands fibers, so with skin biopsy. So it was prospective and blinded study, and the primary outcome measure was correlation between Sudoscan and the feet and skin biopsies, and we look both epidermal and sweat gland nerve fibers at the distal legs. And also we look several secondary outcome measures like correlation between QRSART and several symptomatic scales. Also we compared to correlate it with the Autonomic testing. It was published 2016. And we enrolled 81 patients, more women than men. That's our referral in our clinic. And results did show that ESC, this conductance, was reduced in subjects with abnormal skin biopsies. It's shown in this picture. So patients with abnormal skin biopsy had reduced conductance, and if this was not adjusted, it was significant only for sensory fibers. This is abnormal skin biopsy, normal skin biopsy. But when we adjusted the conductance by the kilogram, by the weight, there was both types of biopsy were highly significant. Actually, sweat gland nerve fiber biopsy was even more significant, which is kind of to be expected. And this is explanation why adjustment is increasing the accuracy of the diagnosis. So this shows dependence between correlation between ESC and biopsy using raw data. And this is the same ESC and the sweat gland nerve fibers raw data. So each point is one patient. You see that the data are kind of concentrated in this area, but there's a lot of outliers over here. And actually, these outliers are causing the distribution is non-normal. And also, we did find out that most of these outliers, they are obese person. So they are kind of skewing the distribution to non-normality. And that's why it was not significant, this difference over here. So when we adjust it by simply dividing by the kilogram, then we find out that all these Sudoscan values were concentrated in kind of narrow range. And then that's why it became more significant. And it was even more obvious when we look on the sweat gland nerve fiber density. So this is the reason why we are adjusting for the kilogram, because it changed the property of the distribution. It became almost normal or normal-like. And this is area under the curve, which is highly significant compared to ESC with nerve fiber densities, and also using the QRSART. But in this study, we did not look under specificity and sensitivities, but this was subject of the next study. And this was subsequent study performed in a completely different population. So we want to verify our previous findings, so we can extrapolate to another patient. So we enrolled 210 patients, different population, and actually this was done at different institution. And also the study was retrospective, it was still blinded. So even during the data acquisition, we did not know the results. So we know the results of ESC and which patient had which biopsy results at the end of the study. And first, This study replicated our previous study, showed that again adjustment from the kilogram discriminated patients with and without normal skin biopsy. Patients with abnormal skin biopsy had decreased ESC, and this was valid for both sweat glands and epidermal fibers. So it is shown over here. So again, patients without adjustment, they had reduced, patients with abnormal skin biopsy with adjustment had reduced conductance, but it was not significant. But once it was adjusted for the kilogram, both epidermal and sweat gland nerve fiber density were significant. But so this was first part of the study. The second part, we have been interested to find out how is sensitivity and specificity of Sudoscan to predict abnormal sweat gland nerve fiber density. So this was the main aim of the study. And we obtained a sensitivity and specificity 64 and 77%, which I think it is a reasonable, good estimation of the sweat loss. The reason is because we realized that we measure sweat gland density from the calf, but this measures global sweat output at the hands and the feet, bottom of the feet. So we are not measuring the same places. There was also high sensitivity and specificity for ENDF, so it was significant for the sensory. Sensitivity was kind of similar than for sweat glands, but specificity was a little bit lower. And also it was kind of to be expected, because we expected this sweat gland or the conductance measure mainly sweat gland activity. And also what is very interesting is that we also, for comparison, look at how much sweat gland nerve fiber density, how it predicts the ENDF, epidermal nerve fiber damage. And it was very similar comparing conductance. And I would just repeat that this is standard for evaluation of small fiber neuropathies, epidermal nerve fiber density. Just again, comparison of the Sudoscan in detection of the abnormal skin biopsy patients, which was significant when it was adjusted for the weight. And here we have diagnostic accuracy markers. This shows sensitivity and specificity of the Sudoscan versus sweat gland nerve fiber density. So this is the main outcome of the study. So it is pretty reasonable curve with sensitivity 64 and specificity 77%, which is again very similar when compared relationship between sweat gland and epidermal nerve fiber density. So even the shape of the curves are kind of very similar. And as to be expected, the sensitivity and specificity of ESC to detect ENFD is a little bit all over, especially specificity is only 55%. So those were our study, and I would like to review a study from Fabry that was published last year, because in our study, we look on the correlation between Sudoscan and skin biopsy. So we look at the small fibers. But in this study, the authors look correlation between Sudoscan and small fiber neuropathy. So difference between biopsy and small fiber neuropathy, the small fiber neuropathy depends not on a skin biopsy, but it's a combination of the signs and symptoms. So it is a combination of the symptoms. So typically, people have burning sensation or dysautonomia together with abnormal skin biopsy. So this is how small fiber neuropathy is defined. So in this study, authors look on the 245 patients. It was retrospective, and they compared skin biopsy, but only ENDF, so it is epidermal nerve fiber density. And they also used quantitative sensory testing, quantitative sweat measurement system, it is QRSART, so it is similar than QRSART, laser evoked potentials, and this is the Sudoscan device. And also they did limited autonomic cardiovascular testing. So those tests typically used for evaluation of the small fibers. Each test is a little bit different, but they provide objective measures of the small fiber activity. And those are main finding of the study. It was shown that ESC itself has a diagnostic accuracy pretty high, and sensitivity was 0.6, which is 60%. And interestingly, the specificity was 89, so it is 89%. So this is sensitivity and specificity to detect small fiber neuropathy. So this is pretty nice results. And compared, for example, like only skin biopsy, so it is very specific, but sensitivity was only 58%. So it is almost the same as on the Sudoscan. And compared, for example, QSART, it was much lower, both parameters. Sensitivity was only 53%, specificity 69%. And this kind of surprise that sensitivity of QST, which is one of the kind of widely available approach, especially in clinical trials, was also was 72%, but specificity was only 39%. So ESC or the Sudoscan was doing pretty well compared to other methods. And the authors also went next ahead. They combined different tests to see if they can increase or decrease diagnostic accuracy. And what they did find out, if you will take a skin biopsy combined with ESC measurement and LEP and QST, so if you have 2 or more abnormal tests, the diagnostic accuracy will be increased and specificity will be 88% and sensitivity up to 92%. So it is a very, very high number. But it requires a combination of the different tests. There was another study by people from France again. They compare ESC with sympathetic skin response. I am talking here about here because SSR is also standard method for evaluation of small fibers. And sympathetic skin response measures a change in skin electric potential in response to an arousal stimulus or an electric shock. Most commonly is used electric shocks. And compared to ESC, SSR has lower sensitivity as well as specificity compared to Sudoscan. We don't use sympathetic skin response anymore, but there are still labs all over the world. They use it. It is very simple to use. It is non-expensive. So you need one simple electric amplifier and stimulator. So there are several studies that show that ESC is valid when using as a one-time measurement. But also what is very important for any diagnostic accuracy, if it is ability to track the disease progression over the time. And there are 3 interesting studies in the literature. In this study from actually this year, patients with diabetic neuropathy and low B12. So in these patients, treatment over 1 year increased plasma B12 levels, as to be expected, but also improved Sudoscan results, suggesting that this method can track the progression of or regression of small fiber neuropathy. In another study using bariatric surgery patients, after surgery of obese patients, ESC was improved after 24 weeks, in addition to A1C levels improvement. So showing that also perhaps ESC can track improvement of the patient with diabetes. And this study, this older study at a patient with hereditary amyloidosis, also ESC was able to track the progression or regression of the disease. So, comparison to other methods for small fiber neuropathy, those are methods which are relatively widely used. They measure similar organ system. Those are functional methods, and there are two morphological. So again, this is QRSART, measures using acetylcholine, SSR, TST, and those are two skin biopsy types. ESC using electric stimulus, the same as SSR. It is very low complexity compared to other approaches, except of the skin biopsy. It's very simple to do, but you need to have pathology lab available. And it is specific for postganglionic nervous system, and it was shown to many studies, it has very high reproducibility. So this is big advantage, reproducibility. And it provides quantitative measurement, and what still needs to be verified if it provides the grading of the abnormalities. We have the measurement, we routinely grade patients for example, for mild, moderate, severe abnormalities, but it remains to be proven how much this have clinical utility or clinical correlation. And it enables symmetric evaluation. Its limitation is at this time it cannot give us the profile if it is length dependent or not, because it measures only the activity of sweat glands at the hands and the feet. And longitudinal studies are available, which is very important. And we don't know if it is sensitive to medication, but probably yes. So in conclusion, it was used so far in more than 200 studies in a PubMed search. It is reproducible, fully quantitative, without habituation, requires minimal patient cooperation, and is more sensitive than SSR, one of the established methods for diagnosis of small fiber neuropathy. It measures both cholinergic and adrenergic activity, which is at this time a theoretical advantage, but if it will be extremely useful if we can distinguish cholinergic and adrenergic dysfunction from the simple measurement. Our data suggests that adjustment of ECS for the weight increases diagnostic accuracy, simply dividing by the weight on the kilograms. It is modestly accurate to detect the loss of pseudomotor fibers, but combination of with other tests increases diagnostic accuracy to detect small fiber neuropathy. Disadvantage of ECS, the same as other techniques, is it cannot differentiate the causes of the small fiber neuropathy. But this is the same as for the other autonomic tests. So for example, abnormal ECS cannot distinguish if this abnormality is because of the diabetes or other causes of neuropathy. And who is interested, there's detailed description of the theory and physiology behind this system. In this very book chapter, it is very detailed and excellent description of the theory. And I will finish here, and thank you for your listening.
Many thanks for the excellent review, and also